Since Dr. Atul is on his way, we'll have Neuro-ophthalmology X-Files as our next talk. I have modified the title a little bit to say that there are signs and symptoms that I don't want to miss in my neuro-ophthalmology practice, and this I'll illustrate by discussing some of the cases. So let me give you an example of this case. This was a guy who traveled to India from abroad, and he said that in his country he was hit on the head repeatedly by the soldiers, and after that he said my eyesight gradually went down. His visual acuity in the right eye was very poor, and this is how his fundi looked like. So this is the history. This is the fundus. Left eye vision was not bad. He was given a diagnosis of traumatic optic neuropathy in the right eye and was told that nothing can be done. And he came to India for the second opinion. What do you think? Any cause for concern? Things I don't want to miss. What do you think? He was given a diagnosis of traumatic optic neuropathy in the right eye and was told nothing can be done. This is the history with which he came. His visual acuity was 1/60 in the right eye and left eye was 6/6. Any cause for concern? Do you think this is traumatic optic neuropathy? Yeah, obviously, because it is being presented as thing not to be missed, you know that it is not traumatic optic neuropathy. Question is, why would you say that this doesn't smell like traumatic optic neuropathy? What do you think? Here, anything that you think is not syncing with the picture? Don't worry about this. This is my mentor who sent me the case. One time when I presented this case, that patient looks like having exotropia. This is not a patient. This is the doctor. Yeah. What do you think? Any cause for concern here for the diagnosis of traumatic optic neuropathy? My cause for concern is gradual loss of vision. All right. When you give a diagnosis of traumatic optic neuropathy, when there is a trauma, either because of a direct trauma to the optic nerve or indirect trauma to the optic nerve, vision goes down and it stays there. 1/3 of those patients, there can be improvement in the vision. If patient says that I had trauma and my vision is going down gradually, it can be either something else, trauma was incidental, or is there any other way by which trauma would be related to gradual loss of vision? Is there any scenario where I will say no, this gradual loss of vision is related to his trauma, to the orbit? Yes, it can be something else, not related to the optic nerve. Was it uveitis? Was it glaucoma? Was it something else? Or if I say if it's a neuro-ophthalmology related problem, optic nerve related problem, can it be, is there any situation where patients say gradual loss of vision? I'll say no, this is related to trauma, neuro-ophthalmology problem. Exactly. So here I got the answer first, is that if there was a history of trauma and if there was a fracture and if the bone fragment was sitting on the optic nerve, that bone fragment acts like a compression. It causes compression of the optic nerve leading to gradual loss of vision. This is the only scenario where you say, okay, gradual loss of vision related to the optic nerve is because of bone fragment. Otherwise, you don't find a gradual loss of vision in patient who has trauma. So that's one cause of concern. Any cause of concern here? This is obviously optic atrophy. Any comment on this nerve? I heard somebody actually giving demonstration like this. So this eye, if you see carefully, the pole, superior pole and inferior pole looks reasonably all right. Though here and here there appears to be some pallor of the disc. Right? This there is no doubt. Here if you see carefully, the poles are fine and there is a pallor here, there is a pallor here. What is that kind of pallor called? Bowtie optic atrophy or band shaped optic atrophy. Where would you see it? Where would you find a bowtie optic atrophy? Okay, let me ask you a simple question. What is this? Macula. What fibers come and attach here? What fibers? Papillomacular bundle. What fibers attach here? Arcuate fibers. Arcuate fibers are temporal to macula. Okay, and all nasal fibers attach like this. They come and attach like this and attach like this. So fibers nasal to macula, they attach in the horizontal raphe. So nasal fibers serve which visual field? Temporal or nasal? Temporal visual field. So if there is a disease process which is causing a complete or partial loss of a temporal visual field, it can affect the nasal fibers. When we say nasal fibers, we are talking about fibers nasal to macula. So what disease process would cause a predominantly temporal visual field defect? Chiasmal compression, because that's where the crossing is. So when you see this kind of picture where you say that there is a band shaped or a bow tie optic atrophy, you are looking at something which is compressing or causing a damage to the temporal visual field and a nasal fibers. Is it clear? What are the other ocular or neuro-ophthalmic features you look for? Now I say yes, I agree with you, this patient does not sound like traumatic optic neuropathy. What would you do next? What is the next step? It doesn't sound like traumatic optic neuropathy. What is the next step? Imaging. MRI of hip joint is also an imaging. So complete answer, yeah. MRI, brain and orbit. Please remember, in most instances, almost all instances, for our concern, that is ophthalmologist, as an ophthalmologist, if we are ordering neuroimaging, we are ordering for brain and orbit. If I give you orbital films of CT scan or MRI scan, you actually will be able to see orbit. Why do you have to mention specifically MRI, brain and orbit? Any idea? Might have to be a little loud. I know you have been drained out by 12 hours, but yeah. It is because of the angulation, absolutely right. Though brain you will be able to see the orbit, but the orbit angulation and the brain angulation is different. So to see orbit and the optic nerve clearly, you need to have a separate cuts for the orbit or a separate reconstruction, whatever may be the case in neuroimaging. So the complete answer is I would advise MRI, brain and orbit. And your area of interest in this case? Optic chiasm. What is this? Is this MRI or CT scan? What is this? MRI or CT scan? MRI. Why did you say that? Soft tissues are visible, bones are not visible. Alright. And is it an axial scan or a coronal scan? Okay. And again, as Dr. Fairuz was mentioning, mid-axial, you are able to see the lens. So MRI axial scan, and this is what the patient was having. This is pituitary adenoma which was compressing on the optic chiasm. The history of trauma was incidental. And that's how he went for a checkup, and that's how he discovered that patient had a problem. Now the question is, what other ocular or neuro-ophthalmic manifestation this patient may exhibit? What are the other signs that you look for or you will see? One I showed you was bend-shaped optic atrophy. What else you may find? What about visual field defect? What visual field defect you will find here? Bitemporal hemianopia, or would this patient exhibit something else? Bitemporal hemianopia is what generally would you see in patients with chiasmal compression. But here, the picture is a little different. What would you... Bitemporal hemianopia is one of the commonest presentation of chiasmal compression as far as visual field is concerned. But here, yes. Junctional scotoma is what you will find, because here you know that right optic nerve has atrophied. Right? So you probably would find a complete optic nerve kind of defect here and a temporal defect here, leading to junctional scotoma. So chiasmal compression, the first thing, visual field defect. Various types of visual field defects that you may encounter would be a complete bitemporal hemianopia or an incomplete bitemporal hemianopia, which might be more prominent superiorly or inferiorly. Or a junctional scotoma. Junctional scotoma, where one eye would exhibit optic nerve kind of defect. It could be central scotoma, centrocecal scotoma, complete generalized reduction of visual field, or a complete obliteration of field, and a temporal defect here. What else would you find? So that is one, visual field, bitemporal hemianopia. What else would you find in somebody who has chiasmal compression? Any other features? What kind of nystagmus these people might show? Seesaw nystagmus. So the second feature in patients with chiasmal compression would be seesaw nystagmus. Anybody has any idea who described it first? It's called seesaw nystagmus of Maddox. Right? Maddox was the first person who described it. So seesaw nystagmus of Maddox, visual field defect which can be bitemporal hemianopia or a junctional scotoma. Any other defects? Bow tie or bend shaped optic atrophy. Anything else you will find on your clinical examination in patient who has chiasmal compression. Two more signs. So what happens if I'm concentrating here at the point of fixation? I'm converging, right? And whatever is beyond this point of fixation falls on my temporal visual fields. Absolutely right. Post-fixational blindness. I'll ask Dr. Ramesha to pass on one gift for you. So post-fixational blindness and hemifield slide phenomena, these are the two other features of chiasmal compression. Now you can encounter it in a MCQ, in a short note, or if you mention it in a short note or a full question or in a viva, you will earn more points. So chiasmal compression, bitemporal hemianopia, junctional scotoma, bend-shaped optic atrophy, seesaw nystagmus, post-fixational blindness, that is area beyond the point of fixation falls on your temporal field which are gone because of chiasmal compression. So you cannot see anything beyond a point of fixation, and hemifield slide phenomena. Anybody knows what is hemifield slide phenomena? So both temporal visual fields are gone. So there is no retinal correspondence which is left, right? Nasal field, the corresponding retina is here on the temporal side, same on the other side. So there is no retinal correspondence because both temporal field are gone. So if there is no retinal correspondence, there is no incentive to fuse. So people who are prone to have phoria, those phoria get converted into tropia. This phoria are phoria because patient wants to fuse. But because there is bitemporal hemianopia, no retinal correspondence, there is loss of fusion and the phoria becomes manifest. So that is called hemifield slide phenomena. So these are the features of chiasmal compression. Important case for your exam and also for your practice. Remember, chiasmal compression is the most common neuro-ophthalmic entity which is misdiagnosed as either optic neuritis or normal tension glaucoma, and it is the second most common cause of medico-legal problems in the US. The commonest neuro-ophthalmic entity which goes to the court is papuloedema, and second most commonest entity which goes to the court is this. So what we learned from this case, if you had listened to your patient, probably you would have known that this is not traumatic optic neuropathy. Okay? And the second take home message, any visual field defect which is predominantly temporal, be careful. It could be chiasmal compression unless proved otherwise. Let's move on to case number 2. So this is a 45-year-old female who has uncontrolled diabetes. She was advised cataract surgery elsewhere. The old report mentioned, optometrist mentioned that maybe there is RAPD in the right eye, but it was an optometrist report. And she started developing some visual discomfort. She was told that all her problems are related to diabetes, nothing to be done, blood sugar to be controlled, come back fast for cataract surgery. As good ophthalmologists, we want to make sure that cataract is taken out. So that's what she was advised. I need your help to tell me whether were we on the right track? Should we have, or should we go ahead and do cataract surgery for her? What's the first impression? What is this? Right ptosis, excellent. Now see what happens here. I have purposely used the torch to check ocular motility. As Dr. Fairoz and Dr. Ramesh has mentioned, next thing is ocular motility. Patient looking to the left, patient looking to the right, Patient again looking to the left. Patient looking up. Yes. So, should we post off for phacoemulsification or something else is needed? Your observations. First of all, is a problem related to diabetes? Yes. Why do you say so? You are a good general ophthalmologist. That means you will do cataract. Control sugar, go ahead and make sure cataract is taken off. Why do you say so? It's possible, but you need to justify. Why would you say that this is problem related to her uncontrolled blood sugar and nothing else? Okay. As I said, there is a reason why I checked ocular motility with the torchlight. Let me show you once again. So all of you agree that there is a ptosis of the right eye, and there was an adduction limitation of the right eye. Elevation, limitation of elevation. Any other point? A very important point? Excellent, excellent. So right pupil is larger than the left pupil is what you have observed now. Now would you like to tell me whether is this related to diabetes or something else? Elevation deficiency, acute onset ptosis, pupil dilated on the same side. Sounds like third nerve palsy. What is worrying you here? Yeah, what is worrying you is pupil is large. If pupil is large in a scenario in the setting of a third nerve, what is it that is bothering you now? Absolutely, compression of the third nerve. As was mentioned, if the pupil is involved in third nerve palsy, you are worried about a compressive lesion of the third nerve. What is the commonest compressive lesion of the third nerve? Can't hear you. Aneurysm of posterior communicating artery is the commonest compressive lesion of the third nerve. And so that's not related to diabetes, because diabetes, generally speaking, would not cause a third nerve palsy with involvement of pupil. So that's the reason why you're not looking at a third nerve palsy because of diabetes here. And as you very rightly pointed out, what is the next step? Cataract surgery? No. What is the next step? MRI of hip joint? No. MRI brain with MRA or CTA, right? Because you want to rule out aneurysm of a posterior communicating artery, which would be picked up by MR angiography or CT angiography, right? So please remember, if you see a patient with third nerve palsy, first thing that you need to observe and tell your examiner is pupil involved? Is this patient having anisocoria or patient is not having anisocoria? That's the first thing you need to tell your examiner. Now, in this case, let's say if I say no, pupil was not involved, will your management be little different? Pupil was not involved, but the same case, ocular motility as shown here. Would your management be little different? Patient has uncontrolled diabetes. Please remember, this is very, very important point. Please note it down. Rule of pupil, that is involvement of pupil in a case of third nerve, applies only to complete third nerve palsy. So if you see a patient with a complete third nerve palsy, whether it's complete ptosis, elevation, adduction, depression is limited, and now you say pupil involved or not involved, you're fine. Patient coming to you with an incomplete third nerve palsy, rule of pupil does not apply. So patient comes to you with incomplete third nerve palsy, you're not very sure whether patient is harboring aneurysm. You can't let the patient go because, and I'll tell you why aneurysm is so important for you to diagnose. So if you see a patient with incomplete third nerve palsy, you need to still go ahead and advise MRI brain with MRA or CTA, whatever may be the case. It is very, very important. The reason is it might be an evolving third nerve palsy where people might get involved little later. 86% of all aneurysmal palsy. 86% of all third node palsy, which comes because of aneurysm, comes with pupillary involvement on presentation. So what it tells you, 14% of all palsies which are because of aneurysm may not have involvement of the pupil on presentation. Okay, so one, if it's incomplete, you need to go ahead and advise MRI brain with MRA. Two, if it's complete, pupil not involved, get the patient back to the clinic, see him again after 1 week, because pupil might get involved little later in the disease. Is it clear? Now why this aneurysm, why it is so important? Remember, third node palsy with pupil involvement, if has not been investigated, is a medical emergency. It's an emergency. Even if patient comes to you in the evening, patient should get MRI brain with MRA immediately. Now why this emergency? Sorry? Why so hurry? Aneurysm? Aneurysm can? Aneurysms are fragile, yeah, so? Can cause a subconjunctival hemorrhage? Subarachnoid hemorrhage. So what you're worried about here is aneurysms can burst anytime and can lead to subarachnoid hemorrhage. Now why that is so important? Subarachnoid hemorrhage, around 50% of the patients who develop subarachnoid hemorrhage because of aneurysmal rupture, they die before they get medical treatment. So one, it's a fatal disease. And people who survive this attack, 50% of them have permanent neurological disability. So that's the reason why third node palsy with a pupillary involvement is a potentially fatal disease or can cause lifetime morbidity. That's the reason why it's an emergency. Is it clear? Is there any other scenario in third node palsy setting which is an emergency? Let's say one is involvement of pupil. What's the second scenario which tells you that this is an emergency? Hutchinson's pupil would not come to us first, right? We are talking about an ophthalmologist. He would have had, most of the time he probably would be in ICU anyways, neuro ICU, or would have had neurosurgical team managing him, and you are just looking at the pupil. Now a patient who comes to us and say, oh, this is something which I don't want to miss. One is pupil. What if I tell you that patient, I'm sorry the video is not playing, but what if I tell you that patient had a third node palsy, he recovered. After 6 weeks he comes back to you saying, now it is becoming better. But there are some signs which tells you that these signs are important for me, and these signs can be again, can be pointer towards a compression of the third node. Aberrant regeneration. What are the signs of aberrant regeneration? One example was shown by Dr. Ramesh. There are three things. One, what is described as inverse Duane syndrome. Second, pseudo-von Grafé sign. And third, Zernike's sign, right? Or pseudo-ARP. Sometimes it's also called pseudo-ARP. What is inverse Duane's? What is Duane's? When the patient adducts, there is narrowing of PF. When he abducts, there is widening of PF. Exactly opposite is what happens in aberrant regeneration. When patient adducts the eye, there is enlargement of palpebral fissure. When he abducts, it might be little narrowing. So that's one sign of aberrant regeneration. What is von Grafé's sign? When patient looks down, there is a lid lag. That is von Grafé. So pseudo-von Grafé is a feature of thyroid ophthalmopathy. Pseudo-von Grafé, lid lag in down gaze, but which is not because of thyroid ophthalmopathy. So pseudo-von Grafé sign, inverse Duane syndrome. What is Zernike's sign? Or pseudo-ARP? Can't hear you. What is pseudo-ARP or Zernike's sign? Here, generally pupil might be mid-dilated and it will show constriction when that eye is adducted. So constriction of a pupil during adduction of an eye is also called Zernike's sign or pseudo-ARP. These are three signs of aberrant regeneration of third nerve. Remember, aberrant regeneration is never seen in ischemic third nerve palsy. That's the reason why it is important. If you find aberrant regeneration of third nerve palsy, there are two things: trauma or compression. That's the reason why you don't want to miss out on aberrant regeneration. Alright, let me show you one more case. First impression. What's the first impression? Right exotropia or esotropia? Right esotropia. Very good. So this is also a patient who had uncontrolled blood sugar and was told that all his problems are because of uncontrolled blood sugar. This is what happens when the patient is looking to the left. This is how it appears when the patient is looking to the left. This is how it appears when the patient is looking to the right. Looking to the left. Your comments? What is happening in the left eye? Looking up, looking down. Show you again. Now quickly, somebody should describe this. First impression, right esotropia, okay. Uncontrolled diabetes. He was told that your problems are blood sugar related. Control your blood sugar, you will be fine. Now patient looking to the left. This is what happens when the patient is looking to the left. So there is limitation of abduction of the left eye. Now see very carefully. This eye is adducting. What do you think? Limitation of abduction. If you see carefully, now you can see here there is a limitation of elevation and limitation of mild limitation of adduction as well. Do you think that's related to diabetes? Is there an ischemic abduction limitation, ischemic 6 nerve palsy? Why do you say no? You see a lot of heads nodding, but why? Remember, commonly diabetes or blood pressure would produce mononeuropathy. So either of the third, fourth or sixth nerves would be involved. If you see multiple cranial nerves getting involved, here sixth and partial third, it is not because of diabetes unless proved otherwise. Right? So here you had abduction limitation, 6 nerve, elevation limitation and adduction limitation of the same eye. What would you do next? MRI hip joint, CT or MRI brain and orbit, always. Okay. What are the areas of interest? Cavernous sinus or orbit as well. Orbit also, these nerves are together. Okay. So this kind of picture would not be seen in a brain lesion because third and sixth nerve nuclei are quite far apart. They are together in cavernous sinus or in the orbit, at the entrance or exit of the orbit or in the orbit. How would you differentiate between an orbital lesion and a cavernous sinus lesion? Cavernous sinus thrombosis would be bilateral or CCF would be bilateral, but there are disease processes which would cause a unilateral cavernous sinus problem. So how would you differentiate like this? This gentleman actually had a cavernous sinus problem. How would you say one test saying, oh, this is not orbit, this is cavernous sinus, or this is orbit, either orbital apex or supraorbital fissure? Corneal sensation would be gone in both. One test would be visual acuity. In orbital apical lesion, visual acuity would be down apart from the other cranial nerves. In cavernous sinus, visual acuity would be spared. Okay? So remember, in an ocular motility problem, if it's polyneuropathy, you need to do neuroimaging. If it's 6th nerve, you are looking at 7th nerve and 8th nerve. If 6th and 7th together, it would be in a brainstem or in CP angle. 6th nerve, 3rd nerve, 4th nerve, cavernous sinus, orbital apex or superior orbital fissure. Okay? Alright.